Right. And welcome, Renata, if you want to take it away. It's great to have you.
Thank you. Thank you for having me on this Friday afternoon during your happy hour. I'm really excited to share a little bit about what I do and kind of, who I work for. And again, I'll have lots of time at the end for questions, or you guys are always welcome to email me additional questions if we don't have time to cover them. My name is Renata Ferreira. I am the Director of Value-Based Care and Data Analytics for the San Francisco Health Network and the Zuckerberg San Francisco General Hospital, which is formerly known as just the San Francisco General Hospital. Oops, I cannot advance, so here you go. Can you guys see my second slide?
Good to go.
Great. I wanted to start out just by saying that it's such an honor to be here today, just speaking to the City College of San Francisco community. It's a community that I still feel very much part of. I probably had the best years of my life when I was a student there. I took wonderful classes. I learned so much from my professors, some of which I still stay in contact with and might even be on this call. And I just had a great opportunity to learn lots at CCSF, probably more than when I transferred as a transfer student. So it's a great place to be. I completed my transfer credits at City College of San Francisco with a focus in math and engineering. So I took just about every math class that City College had at the time. And I transferred to UC San Diego, where I completed a bachelor's in mathematics. While I was at UC San Diego, I took a couple of CS classes. So I learned how to code. I took also a couple classes that taught me how to SQL code or SQL. This is where I started to develop a little bit of interest in data analytics. Some of these classes were, the SQL classes were concurrent with some other like upper division, like math analysis type classes. And so that's when I started to develop like a real interest there. When I graduated from UC San Diego, I actually remember sitting on the couch at my house and just crying. I was really worried about what I was going to do with a bachelor's in mathematics. I had no idea. Some of my friends were going to graduate school. Some of my friends were going into like industry type jobs, and I had no idea what I was going to do. So I decided to kind of rely on some of my strengths and some of the things that I learned in college. One of which was really strong problem solving skills. So when you get a degree in mathematics, you just solve a lot of math problems, right? And so I thought this could be a useful skill. My first summer after college, I got an internship at the UC San Diego Scripps Institute of Oceanography. This was my first time kind of dealing with a real database that wasn't fake or made up for a class. So it was really exciting to just kind of learn. I also learned to do a lot of SQL coding there. After I went to become a data analyst at the UC San Diego admissions office, this is where I was actually dealing with student data or students that were going to be admitted to UCSD data. So doing a lot of prediction and modeling to try to figure out how many students we could admit, how many students were going to be waitlisted. And after a while, I got a promotion and I moved to the health center side of things. So UC San Diego has a hospital and a health system. And so I started to learn about healthcare data. When I started this position as a senior analyst, my mind just kind of exploded because the amount of data was so much, and there was so much that we could do with health data that I just quickly became, in love with this work and quickly grew within the organization. And then moved back to the Bay Area, where I became the director of data analytics at the Zuckerberg San Francisco General Hospital. I think most of you know the San Francisco General Hospital. So if you're just driving on Potrero, it's kind of like this old brick building that now has this kind of funky white dome. But the San Francisco General Hospital is just one out of many hospitals and clinics in the city of San Francisco that are part of the San Francisco Health Network. I think some of you might also be familiar with Laguna Honda, right? Laguna Honda Hospital is a hospital that houses a rehabilitation center. And then we also have a lot of primary care clinics in the city, some youth programs, some smaller clinics, and also specialty care clinics. I think what's important to know about this is that all of these different clinics and hospitals are all connected through one healthcare database, right? So no matter if you go to Ocean Park Center in the Sunset, or if you go to the San Francisco General Hospital, your data or whatever is collected about you during your hospital visit or your outpatient visit is all going to be part of one network. And that's really powerful, right? Because if you think about some of the statistics that I'm sharing here on the right, we see a lot of patients. We see about 110,000 patients in the hospital, about 600,000 visits per year, outpatient. We have mental health, we have trauma incidents, right? And so this is the population of San Francisco that we take care of. More than that, because we are a public hospital, about 90% of our patient population is going to be Medi-Cal, Medicare, even uninsured, like the immigrant low-income population of San Francisco. And so there's kind of like this extra need to, to take care of the most vulnerable populations in San Francisco. I want to share a little bit about what I do and give you some examples of how this is applied to healthcare. So on average, the San Francisco hospital receives about $70 million in funding from the state of California. And all of this money is tied to performance metrics, meaning that we have to achieve a certain level of performance in certain quality metrics to get that money. My role ensures that we get the most out of this funding. I also work very closely with other data scientists and analysts to create like visualizations for the data. We track metric performance. We manage improvement sessions, right? So if there's a metric that's underperforming, we meet with clinicians and other hospital leadership to try to get that rate up. And then I also work very closely with California state officials to design or change healthcare policies in California. Seems like a lot of work, but I'll try to simplify a little bit and give you some examples. One of the performance metrics that we track about a total of 80 to 90 performance metrics a year, is a metric on hypertension control. So hypertension is an issue, it's a chronic issue that leads to other issues, right? So for example, people that have uncontrolled blood pressure can be hospitalized more often. They can have heart disease and other problems. And so it's really important not only to, to a metric that we achieve a certain level of control, but also to the patients, right? Because when you have more patients with controlled hypertension or controlled blood pressure, then, it's better for everyone. So in January of 2021, we started tracking the percentage of patients who had hypertension and whose blood pressure was in control, so under 140/90. And what we learned is that we did really poor, actually. We were just below 40 or just above 40%. And we had a goal by the end of 2023 to reach 60% of patients in control. So the first part of the work is just gathering this data, right? So we use SQL. We use a lot of just, critical thinking about defining what it's like to have a patient with hypertension, where in the system we're going to get their blood pressure, where do we get their age, and And so all of these different pieces about the metric. So a data analyst is going to be pulling together all of these different pieces of data, and then creating this rate that we can track on a monthly, weekly, or in a dashboard format. So the next step is, after we have identified that there is an issue that we want to improve, we create what we call improvement sessions with our clinical teams. So we stratify the data by clinic location, by provider, by age, by race, ethnicity, and we try to find some patterns, right? We try to see if maybe there's a clinic that's underperforming, or a provider who has a large panel of patients who have their blood pressure not in control. We try to identify gaps in the care for patients. So we have conversations with doctors and patients to try to understand why their blood pressure is not in control. Maybe they don't have access to healthy foods, right? Maybe they're homeless and the last thing on their mind is their blood pressure. And then we come up with what we call countermeasures or solutions to the problem. And we implement them. And we run these PDSA cycles, which stands for plan, do, study, and act. So we come up with a plan, we implement it, we study, we try to figure out if it works or not. And if it does work, then great. And if it doesn't, we kind of go back and think of another plan, implement, and study again. It's just kind of a cycle of improvement. I wanted to share something interesting that we found about our blood pressure metric. So when we looked at patients, when we take their blood pressure in the clinic versus when they take their blood pressure at home, there was about like a 3 to 5% change in the positive direction, right? For patients that are measuring their blood pressure at home. And we try to understand why, right? So sometimes the patient is running late to their appointment and they are already flustered, and maybe they missed the bus, maybe they ran to their appointment, and then they get there and they have to take their blood pressure. And again, it's probably not going to be in control, right? They're nervous. Sometimes they have to address multiple issues with the doctor. And so we saw kind of like this positive, change in patients who are able to monitor their blood pressure at home. And so what our clinical teams decided to do is to start giving patients a home monitoring device, right? And with that alone, we saw a huge uptick in the percentage of patients who had controlled blood pressures. And it wasn't so much about the fact that they were able to take their blood pressure at home when they're calm, but it's just the fact that they are aware that someone cares about their blood pressure, that someone wants to know that they are improving, right? That they can call the nurse and show them their blood pressure cuff, and somebody cares. And so just having that relationship allowed patients to care more about controlling their blood pressure. The outcome of this measure is that, in 2021, we started at about below 40%, and we are currently almost close to our 60% goal, and it's only April. We have until the end of the year to continue to monitor this program and some other programs that we implemented for blood pressure control. But it's a great sign, right? Some of these interventions that we do really translate into positive, health outcome for the patient, and for us as well, as we're trying to do this type of population health improvement. I wanted to share with you guys today here something that kind of shocked me when I pulled this data. And this is a program that is not really mandated by the state. But when we internally as an institution saw that there was a problem, we knew that we needed to do something about it. So I wanted to share with you a little bit about the opioid overdose problem. I think most of you know that opioid overdose is an issue, not only in San Francisco, but across the United States. But when I particularly pulled this statistic to share with some of our hospital leadership, it really shocked me. In 2020, which was the year of COVID, the San Francisco Medical Examiner Office reported about 700 accidental deaths that were related to drug overdose caused by opioids, which is more than twice the number of people who died from COVID during that same time period. So when you have something like this that you just cover as you're doing some, just data work, you know that you have to do something about this. And so we raised awareness throughout the entire entity and decided to do a couple things using data and using, the power that we have as a city and county medical system to help people. So the first thing we decided to do is just look at what we have, right? We definitely have medication dispensing events, and we have all of that data stored. We have insight into some social determinants of health for patients. So we know if they're homeless, we know where they live, we know if they have some food insecurity. Like we have a lot of information that way. We have demographic data, so we know exactly who the patients who overdosed are and who the patients that have opioid issues are. We also have mental health records, right? So we can figure out what's happening with the patient in all sorts of ways. And we also have access to treatment outcome studies. So there have been a lot of treatment options for treating patients with opioid addiction, and we have access to some of those results. So the data team at the San Francisco Health Network started to really think about this problem, and it's a really complex one, right? It's not one that you can simply give somebody a blood pressure cuff to take home and say, good luck, we're gonna measure your blood pressure, and then it's gonna be good. This is a huge problem. There's so many components here. So we really had to tackle it from all different angles. And I'll share it with you guys a little bit about what we're doing to try to solve this problem. So the first thing is we realized that there is a huge need for education on both the provider side and on the patient side on guidelines for prescribing and use opioids, right? Most people have still there's still some stigma about what opioid medication is and what it does and addiction and all of that. And so educating not only the provider, but the patient is key. We also started to track metrics, right? To just understand prescribing habits by providers. And if providers are offering other types of pain management or mental health counseling that is helpful to the patient. We also started to understand the impact of drugs, right? So methadone and buprenorphine, who are life-saving drugs that are used to treat opioid addiction. And then we also started to track, patients that are continuously on methadone or buprenorphine and patients who are not, and saw some significant changes in the two groups. And then we also started to ramp up access to mental health services, right? A lot of these patients are homeless. They have drug problems, not just opioid drug problems, but other drug problems. Patients have food insecurity. They have other sorts of social problems that also need to be addressed. It's not just the opioid addiction. And then we started to reach out to our community and our most vulnerable patients who have difficulty accessing healthcare because they don't have insurance, because they don't know how to get access to insurance, they don't have the money, right? So all of this was important in tackling this, this project. And what I'm happy to share is just we created this program called the Opiate Treatment Outpatient Program, known as OTOP. And it's just a van. It's actually this van in this picture that roams around the city. You might have seen it before. And just within this van, we're able to provide medication treatment for patients. So we definitely have methadone and opioid dispensing. We also offer counseling services, harm reduction services, and psychiatric service, all within that mobile van. So as an Unfortunately, I can't share any data about the outcome of this project yet, because we're still evaluating, and some of this data is still proprietary to the system. But I can tell you that it was a really positive change, right? We dispensed over 165,000 doses of methadone and buprenorphine, and probably helped save some patients from overdosing on opioids. This van also provides over 8,300 hours of substance use counseling. And we were, just so you have an idea of how many patients that translates a day, we serve about 300 patients in this van. So this van is mobile, can, pull up to like a homeless encampment and, treat people at, where they don't have to seek counseling. We are going out to them. So that's just some of the tactics that we are using to reduce the number of opioid overdose related deaths in the city of San Francisco. And hopefully some next time that I get to share with you guys some positive data, more specific data about this program. Last, I just wanted to say that, being part of the San Francisco Department of Public Health and the San Francisco Health Network is a really fulfilling job, right? You get to work on projects like the opioid one that I was just describing, where you're having a direct impact into the lives of the community that we live in. I always feel, sometimes I'm really stressed out. I have a ton of data to analyze, but that's the thought that, grounds me to say, like, what I'm doing is important. And I love this job. I also want to share with you guys that we are constantly looking for new talent and people that have a passion for data analytics and are interested in, just kind of becoming part of, creating solutions in healthcare. I'm sharing the site here for the San Francisco Department of Public Health job postings, and you can search this particular title, which is the healthcare analyst position. There is, you can read a little bit more about the job description and kind of what you have to do. It's a little complicated to navigate the city system, but I'm here as a resource. You can always reach out to me if you have an interest in joining. It's a pretty competitive salary. So even as an entry-level position. So I highly encourage all of you to check out the job postings. And that's all I have for today. Here's my email. You guys are always welcome to reach out and ask questions if we don't get to during this time.
Thank you so much. That was great. So if you have questions for Renata, kind of the style is that if you'd post those in the chat, and then we'll take a few minutes to have Renata look those through and see if there's any that she can answer now or might have to respond later. But yeah, post them in the chat if you have a question that you'd like to share. If you'd like to ask out loud, you're welcome to raise your hand, and you can ask that way as well. Just a few minutes to write up what they need.
All right, so I see a question. With your experience in public health, I was wondering, what do you personally think is the most important part of diagnosing problems like the opioid problem? So I think the most important part in diagnosing problems is, so just diagnosing a problem is easy, right? You can go find data and you can find the problems. I think the most important part of this work is actually making your data meaningful to bring about change, right? Because I mean, you can diagnose a problem and then it can just sit there forever. And we have problems that we just literally put in the parking lot. We don't have time to address every single problem, right? And so the most important part is to like actually diagnose a problem and be able to act on it. All right, let's see. I'm going to type in my email here in the chat. Then you guys can all have my email. I have a question here. Is the main language for healthcare R, or is it just clinical research? So actually, we only use SQL. So all we're trying to do is gather data for these reports, and then we create data tables in using SQL, and then we use Tableau or some other visualizing software to create graphs and create reports. But that's the main language that we use is SQL or SQL. Is it SQL or is it SQL?
Potato, potato.
You mentioned there is one network for the database in the general hospital. Does this plug into a federal or international database? If so, how is this data shared beyond SF? So the database is for the city of San Francisco with all of the different hospitals and clinics for the network. But we use a software called Epic. Epic is one of the most common softwares used for electronic charting. And so within Epic, all of the Epic clients are able to exchange data. So for example, UCSF, which is another hospital in the city, they're also on Epic. And so we, through the same platform, we are able to exchange data. So we can see when a patient is admitted at UCSF, and UCSF can see when a patient is admitted at the general. So there is kind of like that interoperability between the two systems if they are in the same, if they have the same vendor, which is Epic. There's nothing federal, like we do receive some data, claims data from the state of California, like, the health plans are able to share data with us, but there's nothing federal that we are able to see. So if somebody gets admitted in like Maryland, like we won't know that information. There's a question here. What is the difference between data analytics and data science? I think I'm going to ask Sean to answer that.
We'll talk about that one in class for time's sake.
Okay. Let's see. Thank you so much. The SF overdose prevention plan was released in early October of last year. How are you and SFGH involved in this plan? Besides the amazing van solution, are there metrics, specific strategies, and things that are being met? Yes, so the van was only one example of many different solutions that have been proposed for preventing overdose deaths in San Francisco. So I am mostly responsible for data sharing as an outcome, right? So we have built metrics that look at the percentage of patients who died last year versus patients who died, this year. So tracking. We're also looking at the outcome of using methadone and buprenorphine as medications for treating opioid addiction. So I am responsible for all of the data side of this. So every time people who are directly involved with these programs, they will usually send me an email and say, hey, Renata, wondering if you can build this metric for me. I'm trying to figure out like if what I'm doing is making an impact. So they'll email me directly. The next question is, are you responsible for helping to come up with some of these solutions, or do you strictly present data? I wish that my job was just to strictly provide data, but it doesn't quite work that way. I think you get so involved and so passionate, especially I'm a really passionate person. And so I get really involved with these projects. I myself, one of the metrics that we have is about counseling patients on quitting tobacco. And so I myself have done patient calls to actually call patients and say, like, please use this resource, if you're looking to quit smoking, right? So there's no way. I always end up getting involved, and it's usually a really collaborative process. So people are able to brainstorm and provide solutions. And then we have a system of picking what solutions we think are going to work based on previous experience, or what's going to cost less, or what's the biggest impact. So we have a way to kind of filter through the solutions. How do you keep your job skills current in your field? So I was certified through this software company called Epic. So I am able to securely pull data from their data systems. I know their databases, and I know the structure of how data is stored. And so every year they require that we do trainings and take exams. So at least 2 to 3 weeks per year, I have to study changes to the database and study kind of different ways that they're collecting patient data. And then I have to take an exam at the end of the year to renew my license every year so I can access their database. I am currently a public health major. That's great. What more technical courses should I take to pursue a career path in this field? Thank you for your presentation. So I think I think being a public health major is such a great major, right? Because it's giving you a bunch of different experience and kind of learning about not only problems, but a lot of different ways that public health works, not only in California, but other states. But I think if you want to get technical, it would be really important to learn SQL, right? It's the language that almost all healthcare entities use to do data analysis, right? You're pulling data and then you're visualizing it using Tableau or another software. So as long as you have that combination of knowing how to use SQL and knowing some visualization techniques, then you're good. All right. Hi guys, for background, first year applied math and CS major. How would you compare the tech to medical environment for data scientists in regards to pay, research, and communicating your findings? I personally have never worked in tech. So as you can see, like my whole career path has been like in the university and the public sector. So I'm probably not one to comment about tech. I think, and I was talking to Sean a little bit about this prior to this call, it's just, there's a huge sense of accomplishment when you work in a environment that is for public health, that you're, especially when you're working with really vulnerable populations like the populations that we serve in San Francisco. So for me, yeah, it's important to have a paycheck, and I have a pretty good one, which allows me to be comfortable in life. But for me, it's more about the the kind of the gratifying results of the work. But I still think the city tries to be very competitive with tech jobs, because they know they're competing with people that are applying to to tech jobs as well. I think I am lost. Here you go. In terms of addressing the opioid epidemic in San Francisco, does the team also have a focus on data-driven solutions in preventing, treating HIV? recently it's become a huge issue with the epidemic as well. I'm not sure if it has faced that problem. So we also have a couple of HIV metrics that we track, and have also noted some data trends kind of trending in the not so positive direction. So we also, I think I was particularly focusing on the opioid discussion, but that van that I was showing in my slides also is able to treat patients that are HIV positive and provide counseling. So they're trying to expand the services that that van can provide, because they know that's part of like what the community needs, right? It's not just for opioids. So there, we definitely have a HIV clinic at the San Francisco Health Network that treats patients, specifically patients with HIV. You may have even seen our booth at like some of the health fairs, or like the, some of the not health fairs, but just like regular street fairs in San Francisco. We provide like, medications, preventative medications, and so it's all being thought about. I think I gave you some examples of what we do, but like you can expand this to like preventative care for cancer screenings, to HIV, to influenza and COVID vaccination. Like, it's a huge amount of issues that we track. I think I will answer a couple more. Looking back on your time as a student, is there something you wish was covered or covered more in your data science courses? I will say that 90% of the work that I do today, I learned on the job in terms of data work, right? So like pulling SQL and like thinking through and visualizing. But I think the part that most people forget is that the skills that you learn during your math classes are so important in this work. Learning how to problem solve, right? Knowing to like state your variables and, state your unknowns, just simple problem solving techniques. That really got me through thinking some really challenging, things that I come up with in my job every day. But if there was one thing that I wish that we had done more in undergraduate training, is not work with so many fake databases, right? Like they always give us some like fake Starbucks, like, oh, here, like, I don't know. It's just really sad how you learn SQL. I wish we were learning on an actual database that is meaningful, not like a Starbucks cash register or something like that. The van is sweet. I love the van. I've personally seen the van around the city too. Are there any plans to add more of the methadone counseling vans to increase assistance to addicts? I think that we're still very much in that plan, study, do, act phase, right? Where we're trying to understand what true impact, the van's having, and kind of the data that I pulled about like how many patients we're serving. And so I think all of this is still kind of in the, study phase. But I think if we continue to see a positive result, then the city will probably want to invest more in programs like that. Any plans to integrate AI soon? Always. AI is always in the back of, I think, everybody's mind, right? It's probably going to take over the world soon. But so far, a lot of this work is still very manual, and we still do a lot of the data stratifications and the predictive modelings all by hand, right? But I think there is an interest, probably not just money yet for it, especially in the county and city of San Francisco. And here's the last question. How long do the PDSA procedures typically take? The one you presented mentioned the blood pressure was for roughly 3 years. So probably the most PDSAs complete cycle in the first time frame, and how much pressure does your team get for analyzing the data quickly, even as it changes? So it depends, right? We have PDSA cycles that last a week. We have PDSA cycles that last a year, right? So it kind of depends on what you're trying to implement. Sometimes like the blood pressure monitoring devices that I gave as an example was very much a really long PDSA because we need to get funding, right? To get the blood pressure cuffs. And then we had to like create permission slips for patients to take them home and to give permissions for us to use their data. And so like all of this takes a whole lot of time. So sometimes these PDSAs can last 1 to 2 years. But I think once the program is in motion, there is always a lot of pressure to get timely data, right? They want to know, like, is this working? So usually within a couple weeks, we try to plan it to give people feedback.
Right on. Thank you so much. That was amazing. You answered all of our questions. Any last minute questions that and anyone get a chance to ask or want to ask out loud? I know we were blasting through the chat there. Oh, that was great. Thank you so much.
Thank you. I'm just gonna type my email really quick here in the chat, and you guys feel free to email me with any other questions.
Right on. Well, thanks everyone for being here, and I'll let you know about the next talk.
Thank you so much.
Have a great weekend, everyone.
Bye.